This talk. Ravi's topic is on giving away to increase profits, primarily looking at healthcare pricing. Before we get to the talk, let me briefly introduce Ravi because his accomplishments are too many to cover in a minute or so. But Ravi is currently the Colonel William G. and Anne C. Svetlich Professor of Operations Research and Management at the Ross School of Business. He's also the founding faculty director of the Center for Value Chain Innovation, the chair of the President's Advisory Committee on Labor Standards and Human Rights. He was also the founding faculty director for the Ross Master of Supply Chain Management program, and he ran it from 2008 to 2015. He's currently a research fellow and the board member of William Davidson Institute. And I personally read many of his cases that he registered at Davidson Institute, and they're great use for sustainability and other supply chain issues. He currently serves on the Fair Labor Association, and his main research areas include technology and business innovation, global supply chain sustainability, and healthcare delivery in low and middle income countries. Most of us know Ravi because of his popular book on managing business process flows, which I think ran many editions. And under an USAID grant, he has assisted University of Johannesburg, South Africa, to develop a graduate degree program in supply chain management. At Michigan, he teaches several classes, and I know he has got several awards in teaching, particularly in global supply chains, innovations in global health delivery, and sustainable operations and supply chain management. So without taking much of this other's time, let us welcome Ravi to this fantastic talk. We look forward to it, Ravi.
Yeah, thanks, Debjit, for that generous introduction. Can you guys all hear me? And are you able to see my slides? I'm in a slideshow mode. Debjit, can you hear?
Yes,
can you see the slides?
Both
okay, good.
Yes.
Yeah, so this is a paper that is co-authored with Jacob Chestnut and Hansu An. Jacob was our PhD student here. He's now a faculty at Cornell. And as I was mentioning a little bit earlier, Jacob was able to join. Actually, he is on the call on this session. So, you know, I would invite him to jump in, you know, for addressing questions or offering clarifications. But I thought before I jump into the specific talk, I'll take a few minutes just to talk about, since there are, you know, junior faculty, PhD students, etc., in terms of how I got into the healthcare space. You know, I didn't start with this particular paper. So this is kind of a little bit of a journey. More about 10 years ago now, I took a sabbatical. So I was actually in India at ISB in the Center for Health Market Innovations, and really not for, you know, working on any paper or something. I really want to understand the healthcare landscape in India. And that ended up a semester engagement. Ended up with 2 case studies, one with Operation Asha that does TB treatment, started in Delhi slums, actually a fantastic last mile delivery model. And then I was interested also, there was another case study I wrote where ITC through its Each of All network partnered with care hospitals to deliver comprehensive healthcare. So those 2 case studies came out of those, that sabbatical time frame. Came back and designed with a colleague a course, a half semester elective class on innovations in global health delivery. And we also were part of a broader outreach in global health. So global health is primarily focused on, you know, thinking about supply chains for delivering drugs in low and middle income countries, primarily sub-Saharan Africa. So there was a board that was there, People That Deliver, which was focused on supply chain workforce. I was one of the founding members in that board. Then became very closely involved with the Global Health Supply Chain Summit. I presently co-chair that. It's an annual conference that we host, usually in sub-Saharan Africa, that brings together practitioners, policymakers, donors, and academia. It's really not an academic conference. It's more a practitioner conference. We did the 12th summit last year in Johannesburg. And this year, of course, we'll probably go virtual given the COVID situation. Also did some work in Africa, distribution costing study. How much does it cost to move a product from, let's say, a central warehouse to the last mile delivery points? Did some case studies. So there's a lot of, just to kind of give a background that it's not I have the luxury of being tenured and chaired, so I don't really have to pursue the next academic paper. So this may not be a great strategy for junior faculty or senior PhD students, but I find this to be very satisfying, and I use many of these concepts in my classes in the global health delivery class also. Many of these interactions also led to what I might call advocacy pieces. We wrote an op-ed piece in the Lancet Global Health that was published on World TB Day on what's wrong with how tuberculosis is delivered today. Piecemeal approach, so that op-ed was tuberculosis control needs a complete and patient-centric solution. Really coming out of my learnings from working very closely, understanding what Operation Asha does in India as well as in other countries they have actually globalized. That led to an invitation to a World Bank USAID workshop on what are the various models for public-private delivery in sustainable TB control. More recently, actually working with one of the keynote speakers at our conference, we wrote an op-ed, kind of informed op-ed piece, if you will, about how medicine access becomes problematic because of regulatory obstacles that every country in sub-Saharan Africa puts up. So the idea that couldn't the different countries coordinate to think about their drug regulation, because that would improve medicine access. So switching to research, some research projects. So before I switch to the specific paper, currently, so all of this healthcare kind of, what I'm saying is that I didn't come to healthcare from a research angle. I came from, trying to understand the field and trying to understand, case study approach and, conference, etc. Really understanding what's going on. And once you immerse yourself in a domain, obviously there are many of these domains are very, very complex, and there will be interesting research issues. All of those also pulled me in the United States healthcare context. So I have now sequentially two different PhD students, one who has graduated. We looked at what's happening with generic pharma in the United States. Why is there so much market concentration? So this is more of a structured modeling approach to understand market concentration in generic pharma. She has graduated, the student, she's a faculty at UIUC in Urbana-Champaign. And then currently ongoing work is to look at generic versus branded pharma, which is the prevailing notion is that brandeds are as good as generics in the sense that, at least in the United States, to get a generic into the market, the company has to prove biosimilarity. But we are looking at actual data, multi-year data from insurance data to see, and our initial results show that actually they are not equivalent. There are both health implications as well as economic implications of switching from branded to generic. So we're still kind of, continuing that research. It has also pulled me a little bit into India. We have begun to do some work with the emergency response systems, the GVK-MRI. Some of you may be familiar with the 108 ambulance service. In India, GVK-MRI has become the world's largest emergency response operator. So we're doing some work. We have an MOU with them, University of Michigan. There are many elements to it. My focus really there is to understand the key determinants of performance assessment, performance measured as response time. So this is a classic operational kind of problem. Earlier this year, got pulled into the national insurance scheme, Ayushman Bharat, and with folks in cardiology and All India Institute of Medical Science, cardiology here and AIMS in India, trying to do some work on cost effectiveness analysis of cardiovascular intervention. So, I mean, that's kind of the broader landscape of how I got into this. In between was this intervention, which is the focus of this paper. And really the context here is, I have interacted with Aravind Eye hospitals for many years and know them very, very well, more from an MBA project perspective. And I'm assuming that almost everybody on this seminar today knows about Aravind Eye hospitals. Is that a fair assumption, Debjit?
I would hope so, because of we have written also many cases with them.
Yeah, so I assume so. So therefore, the first few slides may be not news to you, but I would walk through anyway. These were developed by Jacob when he gives seminars here. I think this was a job talk, right, Jacob? You're muted.
It was my job talk.
Yeah, it was a job talk, right? So, so Arvind, so if there's anybody who doesn't know, and I would highly recommend you should go visit them in Madurai. It's the world's largest ophthalmology hospital. The basic idea is to set up a low-cost, high-volume, high-quality kind of setup. So very high demand, very high throughput, more like an assembly line type of surgery system, if you will.
Ravi, just to interrupt, I think your slides are not floating. I think you are still in the first slide.
Really?
Yeah.
Maybe what I should do, does the slide show now?
Your slide is showing, but still the first slide. What about others? Yeah, now it is moving.
Now it's going.
Now it's going. Maybe
So I think maybe in the slide presentation mode, it doesn't move.
It was never in presentation mode. So
no, I do in the presentation mode here.
Okay.
But when it displays through Zoom, it probably doesn't move.
You can use the view mode there.
Sorry?
Use the view mode, it works.
Within Zoom or within?
No, just next to that slideshow mode, view mode. Little left, yeah.
This one?
Yes,
Yeah.
it's working now. Perfect. Yeah.
Oh, sorry. Okay. Yeah. So you didn't see any of this stuff, but that's okay. You know, this is what I was showing in terms of courses. But anyway, you can distribute the slide deck later. Are you able to see this?
Yes.
Yeah.
Okay. So also, as many of you may know, they have backward integrated into production. They produce their own intraocular lenses. They have so it's kind of a vertical integration story as well, where many of the supplies and devices that they need are in-sourced, if you will. And the volume story, average number of surgeries per surgeon per year. So this is kind of their skill set and the high throughput story, which should be familiar with you. So I've, looked at this Arvind situation many times. I've co-advised 2 or 3 MBA projects there. So I've been to Madurai many times. It kept kind of coming back to me about what their service policy is. The service policy, as you know, that is, they serve any customer regardless of their willingness to pay. And paying customers will self-select, and the selection, the segmentation is primarily based on non-surgical quality issues, primarily, right? So what kind of room do you want? Arvind suite, C-class, shared, and those kinds of things. So private room, creature comforts, etc. Their service mix, if you look at, is basically approximately 50-50. So about 60% are free, the others are paying, and their gross margins are very high. And if you've done the case study, you know all of this stuff cold. But that led to kind of a question that kept bothering us. Okay, so why does Arvind do this? Meaning, why does it serve patients free? Agreed, it's a nonprofit. So is it simply a charitable mission? If it's a charitable mission, one could charitable mission could explain the free service idea. You could also explain it from a marketing angle, word of mouth to generate demand, etc., to get customers in. These are explanations for, in general, why would a business give something away free, right? I'm not saying these are necessarily in the healthcare setting, right? So think about Adobe Acrobat Reader being free, that generates demand for people upgrading into software with more features. Or it could be a loss leader approach. So think from a grocery kind of setting that I could give some products at a much cheaper price, maybe at cost, so that I draw customers into the store, and hopefully in the market basket kind of analysis, they could purchase more stuff. So these have been conventional reasons, so which is understood. What we wanted to also look at basically is, what about the operational? Supposing that none of the conventional reasons existed. Could there be other reasons why we might see free service? So operational reasons could give you that. For example, volume considerations, economies of scale effect. If there are significant economies of scale, then you want to build up volume. So maybe you could do, that could be a reason why you want to increase volume, you might want to give away some service for free. If there's significant learning by doing either on volume and or on variety, and there are economic papers on that one, papers in economics, that is, if you learn by doing, or if, then you go down the cost curve, you improve quality, then that should be another reason to put, to get higher throughput in your system. And that allows you to, decrease cost and increase quality. Or it could be a fixed cost allocations kind of argument. So there could be operational reasons why, all primarily revolving around volume, that could inform why you might give away service for free. The other aspect could be consumer behavior, which is people are rational. That is, behavioral economics literature suggests, and I'll come back to that in the second half of this talk, that there's something special about free good. There is behavioral economics work to show that people value free good differently than even an epsilon priced good. So what the paper is going to focus in on is, if none of the conventional reasons existed for offering free service, we focus on purely operational reasons and consumer behavior reasons, would we see free service, right? Is free service optimal? That's the question we're asking. Not because it is your mission oriented, but if you're not mission oriented, could it still be optimal? So our consumer behavior and operational efficiency is sufficient to rationalize free service. When would you do that? For what reasons? And do you need both consumer behavior issues and operational efficiency issues? What I mean by that is these two, that is, do you need both of these, or do you only one of them is sufficient? So that's kind of what we want to explore in this setting. So the model is simple at some level. So this is, now I'm getting into the technical kind of thing. So we model a monopolist provider. So this is Arvindai Hospital, serves a population of consumers over a single selling period. So there is no kind of dynamic kind of model. There is a per customer cost to serve, which depends on quality and the number of served. So our cost modeling is based on both quality and volume. And the quality, we are using some aggregate measure of service quality. So as I mentioned earlier in introducing Arvind, service quality in healthcare settings could be broadly thought in terms of clinical quality and non-clinical quality. So we're not sacrificing clinical quality, but everybody gets, one standard level of clinical quality, but there could be other options that I could add that could enhance quality, which is not based on clinical arguments, right? So that is why there is a lower bound on this. Service must be ethical. So that is, quality is less than some minimum threshold. So the provider's problem really is, how do you set a menu of quality price to maximize total expected profit? Again, remember that we are modeling a profit maximizing monopolist. So there's no mission orientation here. Consumers are heterogeneous in private preference for quality. So we model that by some theta, which has bounds. And consumers choose quality / price to maximize utility, and utility is modeled as a function of, theta times some valuation for quality minus price. I think the parenthesis is probably shouldn't be here, this last one. So it is theta VQ minus P, right? So utility of type theta who consumes, utility of type theta who consumes quality Q at price P. And it's quasi-linear in price and quality. And we have to assume an outside option for the consumer. That is, they may always choose not to consume the service, and they'll have some value for outside option. We call that delta, right? Some of the key assumptions, we assume that it is volume dependent. So we start with the operational considerations. We will not, at the first pass model, look at the behavioral issues. We start with the operational setting, which is there has to be some impact of volume on on quality and cost. So key assumptions of the current setting: cost to serve is always greater than 0. It's strictly increasing and convex in Q. So the higher the quality you want to provide, the more costly it becomes. Total cost to serve is not decreasing in N, right? So total cost. So overall, as you serve more people, the total cost is going up, but the marginal cost to serve is decreasing in N, which means this is where the cost implication of volume kicks in, right? And this basic model captures two essential features of Arvind's operations. Workers, or in this case, healthcare workers, become more efficient and skillful with practice, right? And in fact, I remember still very vividly visiting at Aravind, sitting in Madurai, and bumped into at the International Guest House this doctor from Delhi, Dr. Jain, who was the head of Numeric Association of India. And, you know, elderly gentleman, he was there asking what brings you here. He says, oh, my son is doing a residency here. I said, you know, why Aravind? And he said, 2 years of residency at Aravind is equivalent to 10 years of work experience anywhere else. Just the sheer scale that Aravind moves through its operations. So this is more learning by doing, but there's also learning by variety because of the variety of patient, and especially when you offer free service. This is from the poorer population. People are coming with more extreme cases, so more difficult cases perhaps. And so the learning on variety also exists within Aravind. There's definitely economies of scale in production. So whether it is in the surgicals and the cataract lens production, or how the operating room theater is set up and all that stuff, there are economies of scale. So our cost model kind of tried to capture that. Now, so the first pass model is really volume dependent pricing problem under asymmetric information. That is, the provider designs a mechanism to maximize expected profit. And using revelation principle, we can basically reduce this. I mean, this is a very classic asymmetric information kind of principal agent model framework. Expected profit, which is price minus cost, and they'll be subject to certain constraints, individual rationality. That is, you know, consumers will opt for service as long as the utility is greater than the outside option. It has to be incentive compatible because as we are doing the pricing based on theta, we want to make sure that people with their theta will choose that kind of service. And we have to ensure some minimum quality, right? So where this model differs from the standard address selection pricing problem is that we allow for volume dependence, which had not been addressed before. So just to kind of, you know, results and implications when everyone pays. So again, we're not offering free service, just a volume consideration. We want to explore how price and quality depend on volume. So basically you're saying this is a model where everyone is paying. Doesn't mean that everyone is served. Everyone is paying, right? If you don't pay, you don't get served. Let's say that's the model. So that's not the Aravind model, but we are focusing only on the volume dependency. The best way to kind of characterize this is this picture below. Basically, you look at the consumer valuations that ranges from theta underscore to theta upper score. And let's see, there was a chat.
For the participants, Ravi.
Okay, sorry. So basically, the valuation range segments. There is a critical theta valuation we call theta P, above which consumers who have valuation above the theta P will pay. The other people are not served. So it's a clear segmentation, right? So which is not surprising. The question really now is how do prices depend on I know it's a lot of math here, but basically what it says is that the quality and price tuple, there is a optimal threshold for quality, and this is how the price depends. And I'll show you some graphs about what this means. And the optimal quality is a solution of this equation. So basically you have something on the marginal valuation as change in marginal valuation based on quality versus change in cost, right? So classic kind of marginal benefit equals marginal cost kind of argument. So efficient quality, the thing to notice is that the efficient quality being offered is a function of volume, right? I mean, that's the key kind of thing here. And how does it depend on volume? So let's take an example. This is best illustrated using a numerical example. Let's take a simple consumer utility that is linear in quality and price. So VQ of Q is Q, which means your standard kind of linear model, theta Q minus P. Some numerical kind of theta varies uniformly between 6 to 10. And we assume some kind of a cost model, right? So the cost model simply says that 30% cheaper to provide quality Q when the entire market is served, right? So this is showing what happens, how much of a discount you would get if you serve the entire market. So what is the volume effect on quality, right? So this is the critical equation, that is marginal benefit equals marginal cost in setting the optimal quality. So this is because remember V of Q was linear, so this is a straight line function. And now we have to look at how cost changes. And what you see here is, what we're looking at is, let's anchor on a type theta customer where theta value is 7. Remember, theta was uniformly distributed within the range of 6 to 10, right? So what this equation basically will say that the optimal quality for the theta type customer theta equals 7 will be such that the tangents of these two curves have become equal. So that's kind of the optimal quality level. Now, let's suppose that you look at what happens to cost if you include 6 also in your mix, then the optimal quality of customer type theta equals 7, if you choose to also include 6, will be a solution of this tangent. Now you can see there is a difference, that is the quality actually is improving because you serve more people. So that's kind of basic insight here graphically that I'm showing that is captured in that math, right? So key takeaway is serving more customers improve quality for everyone. I mean, that's the basic takeaway, right? And of course, the pricing, so that's the quality equation. How does the price depend? What happens to price? Price is a function of this. Now, price depends on consumption utility and consumer rents, which depends on volume. So let's kind of look at this a little bit more in detail. Now, here is the argument. What happens to price is unclear. Increasing volume affects prices in 2 ways. First, as we just showed, that quality will improve. If quality improves, consumption utility increases. If consumption utility increases on the part of the consumer, then it is allowing the provider to charge higher prices. So prices should increase, all else being equal. On the other hand, the way you're increasing, you're getting higher volume by pulling more of the lower valuation customers who are offered service, right? But as you offer service to lower valuation consumers, there's an incentive issue because the pricing is a function of theta. So people who are higher valuation customers may try to switch to a price offered for a lower valuation consumer. As a provider, you may want to prevent that. This is what is captured in the incentive compatibility constraint. So as you add more lower valuation consumers to your service, you're providing an incentive for deviation from consumers who are who have a higher valuation but may choose a lower valuations offering, which means the rents increase, and as rents increase, prices should decrease, all else being equal, right? So there is a push and pull here in terms of what could happen to prices. So volume acts on price in 2 countervailing ones. Which one dominates? That depends on what's really happening, on the equations, right? There is a question here. What could be the interpretation of delta greater than 0? Is it crucial for result? As this is a monopoly, would the results vary qualitatively? Delta is normalized to 0. I don't think that matters, but I defer to Jacob.
Yeah, I'm happy to talk about this. So this is something we actually thought about quite a bit. So this paper has gone through many versions. So what happens when you normalize the delta to 0 is essentially you remove a case. And I don't know, I think the version of the paper that Ravi sent you guys doesn't get into this due to the length of the paper. But what happens is the problem breaks down in terms of parity. So when you get into the free contract, that's when it starts to matter whether or not delta is non-zero. Because in the paper, we assume that the utility consumption benefit of getting something for free is less than delta, okay? It doesn't have to be less than delta, it could be larger than delta. And the full version of the paper deals with both of these. But when you normalize delta to 0, you remove one of the cases. So it's certainly not critical for the paying contract, right? You can totally normalize to 0. It's just basically a financial friction in the system. But it's when you get into the way consumers perceive free relative to their outside option that it matters. So it's debatable whether or not, you know, one of those two options, alpha being less than, you know, the utility kick being less than delta or greater than, is the more reasonable option. But when you normalize delta to 0, you basically lose one, is the kind of long-winded answer. Did that answer your question?
Yeah, thanks, Jacob. I hope it did. So I'm not monitoring the chat box, but
Ravi, I can moderate it. Yeah.
Okay, cool. So going back to, so the impact on price is unclear, as we said. There are two different countervailing forces. So here are three examples actually. So if you, let's say the cost decreases 10% linear discount on marginal cost to serve. If that is the case, then basically price charged will decline based on volume. If you, so rent increases. So basically remember there is a rent argument. Rent increase dominates when volume yields lower marginal savings. So if the marginal saving that you get based on volume is low, then rent increases and therefore you can, and then you charge lower prices. But if the discount that you get because of volume is huge, then you start charging higher prices because the quality improvement begins to dominate. Remember the two countervailing forces, right? How much quality improvement do you get because of higher volume versus how much of rent-seeking behavior you will see because of high volume, right? So if the quality improvement dominates, then you will start increasing prices because you're able to offer higher quality as you increase volume. If it's something in between, you will get some kind of a convex kind of thing, right? So that's what is going on. So there is a question. Okay, that's a comment. I don't know if it's a question. So I don't know.
Yeah, it's more of a comment. Yeah.
Yeah. Okay. So the key point is more volume is not always better. Must carefully balance both volume effects when determining how much market to serve. Right. Now, the schedule depends on the threshold type because the schedule we showed was for a given theta p that exists an optimal service schedule, right? But you can also endogenize this, right? And when you endogenize this, we can call the theta p as the optimal lowest service, right? So that's what we can talk about. You know, that can be endogenized into the system, right? So one way to kind of think about the key feature, we can think in terms of, we define something called a virtual margin. Virtual margin basically saying the direct margin earned from serving a type theta, net the information rents created when types theta p and above are served, right? So assuming the same threshold policy, theta p and above are served, then the total profits basically is an integration of this virtual margin. And if theta p star, which is the threshold, then the virtual margin at theta p star is actually less than 0, right? So the key implication basically is optimal paying schedule serves customers who introduce excess pricing dilution to obtain economies of scale. So basically this is like a loss leader. Remember, At theta p star, the lowest point, the virtual margin is less than 0. So you're not making money on the lowest time that you serve, that you choose to serve, right? But you're not making money, but you still, they are benefiting you because they're allowing you to get more people into the system. This seems like a loss leader pricing. Like, you know, I was mentioning earlier in grocery stores, you may lose money on, let's say, milk or something, but you draw customers into the store. But typically those loss leader pricing in retail setting, the argument has always been a market basket analysis, that is for the same consumer buying multiple products. Whereas here we are seeing something like a loss leader pricing, but across consumers. That is because they're only buying a single good. And this particular consumer, you know, one consumer on the lower end of the theta spectrum, I don't earn money, but overall I earn money by increasing the volume. So that's kind of the key insight that is coming out of this, right? See, the problem is when I do this view, I can't see the last line of this myself. Okay, what about free? So let's get into, so there is, so that's kind of the, without any behavioral implications. So what I'm basically looking at this point is, you know, is there a rationale for fee service that is not just based on volume consideration, but based on behavioral considerations, is what we want to kind of look at next. Just one second. Yeah.
So the thing you couldn't see, Ravi, which is actually kind of an important idea, in this paying contract, you're introducing basically excessive rents to get some kind of economy of scale benefit, okay? So the question we pose, and which takes us to this free contract, is can you still get the benefit of high service volume without the excess rents? Okay, so it would act as basically a secondary screening mechanism. So that's kind of the thinking.
Thank you.
We transitioned into the free contract.
Yeah, and that's actually a cool result, as we will show you in about the next 10 minutes or so. That is, so the excess rent idea, just to kind of reemphasize, is that as you start expanding the market, what happens is people who have slightly higher valuation may begin to mimic like a lower valuation customer and pick the lower price. They may get a slightly lower quality, but that's the rent behavior, that is rent-seeking behavior that's happening. And the monopolist is trying to segment this through the incentive compatibility constraint. So that's what is leading to the rent-seeking behavior. Now, could offering free good change that equation? And then under what conditions might it change? That's where we kind of rely on this behavioral idea. So there is literature in behavioral economics basically saying that productivity discontinuous when pay is 0, right? So anything that is offered, and it's many different contexts this has been done. I mean, there's been done with pro bono work for lawyers, saying if you do, many people come to do pro bono work, but if you begin to compensate them even a little bit, not at the market rates, then many people don't come. So there is something special about things at 0, pricing at 0. There is a very interesting experiment on zero price utility that was done about 2 different goods at different qualities and looking at the delta in the price between quality. What they see is that, so Q2 is a lower quality product than Q1. Product 1 is lower quality than product 2. And they tried to vary in a behavioral experiment the difference in price. Its prices were shifted by keeping the delta constant. So for all prices greater than 0, demand is constant, P2. But when P2 equals 0, the inferior good has 0 price, demand becomes statistically different. So there is some discontinuity in the utility function at 0. I mean, that's the key insight. Now, this has never been shown in healthcare. These are all experiments done in other kinds of settings. But we wondered, you know, at least from a theory perspective, you know, if the consumers who are offered free service get a utility bump, then how would the model change in some ways, right? If you remove money from a transaction. So the key insight from this behavioral literature is that some consumers draw discontinuously high utility when money is removed from a transaction. So that's kind of the key idea here. So the way to model this basically is that as long as prices are non-negative, you have the standard utility function. But at 0, you kind of add a bump, which is constant bump of alpha. So at whatever quality you offer this service at p equals 0, so you have the standard quality rated utility, and you get it because there is no price, you get a bump in utility because of alpha. So we assume that alpha is a common knowledge parameter, it's constant, right? This is the magnitude of consumer preference for free service. So say feel good utility or whatever. So there's a whole measurement issue, which is outside. This is a theory model. I mean, it'd be interesting to kind of think about is how would you measure alpha in the population? Is it even possible to empirically or experimentally estimate that in the, for example, urban situation? But for now, we will assume that because there is a theoretical basis for this alpha bump, what happens? So we can reformulate the provider's problem in terms of transaction utility, same things. Incentive compatibility, higher constraints, they become perturbed a little bit. For the first pass of the model, I'll basically show you, I think that's all the time I have in the next 5 minutes or so. We will hold the service volume fixed. That is, we'll use the same n star that we derived in the previous one, just to compare with the previous model when we did the volume. We'll keep the finite number of customers to be served, and then look at what happens if you serve the same number of customers. Earlier, everybody was being given a price. If price was non-zero. Now, if I throw into the mix the utility that some consumers actually get a utility bump because of zero price, what happens? Right? Again, there's a lot of math here. There is a quality of the free price, for the free people, what is the level of quality, and there is all this, what the premium you get, etc. But so the thing you get is quality is discontinuous. So few insights, quality is discontinuous. There is one quality level for the free people, and then there is the other quality for all the paying customers, which, in the Aravind case, you think about this, the free patients have a certain living accommodation. Everybody else has a slightly different accommodation based on their ability to pay, and that could vary based on what levels they are paying. The surgical quality really doesn't change. The operating room theater is similar, the same surgeons operate and things like that. So I think there is, again, we think about quality in clinical versus non-clinical, there is very little difference in clinical quality. There are a few options that are given in terms of lenses and things like that for the paying customers. And some pay, others don't, and that's kind of what this pricing equation basically says. All right. What we show basically is that if you remember that in the volume-based pricing model, there was a lower bound theta p, and all the customers above theta p were served. What we show is that there's another theta 0 that in this range from the lower valuation up to some threshold theta 0, people don't pay, and above theta 0, people will pay, right? Paying prices are based on the standard asymmetric information prices with some adjustment term that is coming here, right? And the adjustment term is positive in the sense that what you basically see is that in the classical asymmetric information pricing that we showed before, the same set of customers who are above this theta 0 who are going to pay are going to be charged a higher price than they would have been if there was no zero pricing going on. So you're getting a pricing bump for the people who actually choose to pay when you offer free service to some segment of the people, right? What the premium depends on is this kind of a complex equation, right? So I think it's maybe pictorially, let's see, there was another graph. Yeah, I think that's probably a hidden slide. So one way to kind of see this is that here is the asymmetric information quality that you were seeing, which was continuously varying. And now if you offer zero price, the quality level becomes discontinuous. So for people between theta p and theta 0, people who are getting zero price, there is a lower one fixed quality, and then the quality jumps for everybody else who pays, and it varies based on the value, theta valuation. And similarly, price for the people below theta 0, 0, and this thing jumps. The price, this was the original asymmetric information price, and this price is jumping, right? Now, there are some variations you can show. This is the premium that is being, as I was showing you earlier. Now, that premium will shift. So as you begin to offer, so the difference between this graph, this is the theta 0, this is the jump here. If you expand this market, the pricing premium is going down, right? As you shrink the zero pricing range for number of customers who get zero pricing. So that's kind of the key insight here, that the schedule particulars will depend on what theta 0, that is how many customers are you willing to give zero pricing to, right? So why does this happen? Basically, the way to kind of think about this is, remember the incentive compatibility constraint, that a higher valuation customer will potentially mimic to be a lower valuation customer. By offering zero price, what you're trying to do, what you're doing basically is you have dropped the quality, overall quality, again, I want to re-emphasize, it's not clinical quality. Overall quality of the free patients is so much farther down here that these people will not try to mimic like a free patient. So what it allows you to do is disentangle the incentive compatibility constraint for those people who are in the paying region, and that diminishes the rent-seeking behavior that allows you to price a little bit higher for the paying customer. I mean, that's kind of the key insight, and which is actually a very interesting insight in my mind, that your classic incentive, asymmetric information papers are basically trying to think about this rent-seeking behavior and how to model that using incentive compatibility. And by offering a free service and setting a slightly lower quality on overall quality, you're basically breaking that barrier in the incentive compatibility constraint. So again, so this is the key takeaway is how much will that happen is you're potentially losing money on the free servicing, free paying customers, but you're gaining because of higher price, because you disentangle the incentive compatibility constraint for those segments of customers. You're able to charge higher price. So how much margin do you make there versus how much margin do you lose here? And overall, this difference will tell you whether you should go for a zero pricing free service at all. So if you put this in the context of Aravind, basically, right, 60% don't pay, 40% pay, and still their gross margins is like 40%. I mean, that is what is really going on here. Of course, this is mixed in with the volume impacts, etc., right? So I'm going to skip through. I think I'm looking at the clock. There are some comparative stats you can show here. That is, when alpha increases, the bump you get from free service, utility of free service, the quality of free service will decrease, right? The more utility they get from free service, the quality of the free service might, overall quality might decrease. When the seller earns low but positive margin under AS, right-hand side decreases. So this is, so free service is more likely to increase profit, right? So again, this is the cost piece of it. This is the valuation, again, the marginal benefit versus marginal cost, right? So the key takeaway is free service tends to be better when the seller serves lower valuation consumers with high appreciation for free service. So as long as there are people who have high appreciation for free service and they have a low valuation overall, then we will do that. So here is, I think, best illustrated with the simulation. I'll close with that. So this is numerical simulation. The idea is optimal paying schedule earns positive profits at non-zero prices. So you are serving 90% of the market. The way to think about this is, on the y-axis here is the minimum quality. On the x-axis is the alpha. Remember, alpha is the utility bump that one gets with free service, right? Free schedule serves 15% of the paying customers for free, and Q-min is 0.4, approximately 85% of the lowest quality level offered in paying schedule, right? So let's see, it has three segments here. So in this segment, and this segment is high alpha, but also high minimum quality expectation, then free becomes worse, right? So provider gives away fairly high quality and consumers really want free, but paying prices decreases, right? So that's kind of what's happening, and therefore you may not offer free. In this region, free is about 8 to 15% better than the optimal paying contract. So in this region, which is again at a higher valuation or higher alpha, but slightly lower quality thresholds, you get, if you choose to offer in your pricing mix free and paying, your overall profit is actually better than a purely optimal paying contract. And if you go into this region, which is really low bump, but you can even go push up on the quality here, minimum quality, free is still better, but not as better as what we saw here, right? So when I say free is better, meaning better with respect to an optimal paying contract where everybody pays, right? So that's kind of the segmentation. The numerical setting is trying to illustrate this idea that when would free be optimal? Free is optimal as a profit maximizing optimal, not in this region, but it requires a certain level of, it's a combination of what bump you get and how much minimum quality you could offer in this one that is acceptable to them. Yeah. So in conclusion, so I think I'm looking at the clock, I really didn't leave much time for questions. So our consumer behavior and operational efficiency sufficient to rationalize free service? Yes, provided the consumer's preference for free service is sufficiently high and seller's quality bound is low, right? When seller's quality bound is high, free service can be optimal, provided the consumer's preference for free service is not too high, which is this part. Right, so in the quality bound is high, but then I need a lower alpha, right? So that's what this is showing. When and for what reasons? When increased prices exceed cost of free service, free schedule is optimal. So free quality, we have already talked about, less acceptable to high types, acts as secondary screening, perturbs the incentive compatibility provider, raises paying prices. So that's kind of what's going on. What happens if only one of these drivers exist? So that is one of these, meaning the volume versus the behavioral issue. So zero price utility alone is sufficient to give you this result. You don't need volume dependence, but volume dependence by itself is not, assuming total increase can be shown, that if you had only volume dependent, then you will never offer free service. That is, having a fee paid schedule always dominates, right? So that's kind of what the key insight here is. Let's see, I think we have a few minutes for,
yes,
I see something in the chat.
Yeah.
Yeah.
So I think one question was by Prahlad before, in terms of another model he talks about, which is like meditation kind of model, where the people go, they don't charge any fees for the courses, for any accommodation or nothing. It solely depends upon voluntary donations, right?
That's a charity argument, right?
Yeah. So,
so that's why we read out. Assuming that's a charity argument, because charitable organizations can offer free. That's a mission orientation. The focus here is that if you are a profit maximizing monopolist, would it ever make sense for you to offer free service? So we want to rule out charitable organizations because that is a mission orientation. I do this. So take Shankar Netralaya. I mean, they charge also. Shankar Netralaya also has, it's a charitable mission. Now, Shankar Netralaya can also fit in here if you want to choose this, but they also take donations, everybody does. So in a way that Arvind is set up as a not-for-profit, kind of muddies the situation a little bit because we are modeling a for-profit. But, offering free for a charitable organization, obviously, that's their mission, right? That's what they will do. That's not the context we're modeling. We use the motivation for what the Arvind pricing model, and if we're asking the question, would it ever make sense for a profit maximizing monopolist to do this? And we are showing that yes, it does make sense. Okay, there are many other questions coming up.
So another question is by Ganesh. He wants to check what happens when the alpha is different for different customers. So Jacob, you were saying you want to answer.
Yeah.
Sure. So this was something that I also thought about quite a bit, because I think it's natural either for alpha to be type dependent or the outside option to be type dependent. And I looked into the literature about type dependent outside options, and economists don't really look at it that So we focus primarily on the alpha aspect. And as it turns out, so long as alpha is decreasing in consumer type, and so by that, I mean higher valuation customers are less sensitive to free stuff, which I think is pretty reasonable. Not only does the model that Ravi talked about hold, but it actually holds more strongly. There's greater benefit in that instance. So I think that in reality, the alpha probably does decrease, but you know, we're trying to build a parsimonious model and it's hard to fit in page limits and stuff. So I guess the short answer is yes, it works. It works even better. The other issue, whether or not this model kind of fits the Arvind setting. And in the full paper, one of the cases that we look at, and it shows up in here, so the service constraint. If you start on the front end as a firm and say, yes, I'm going to serve everybody, which is kind of the Arvind setup, the free contract works, again, even better because you're no longer endogenously picking the lowest paying type you would compare against. So it works in that case as well, even.
Actually, now that I remember, that's where this has been in the works for a very long time. This was Jacob's first paper, as you, for PhD students, yes. I mean, you guys know that standard business school model is about work on 3 papers and you're done with the dissertation. This is the very first paper Jacob worked on. And, you know, I had been struggling with this for a very long time, saying, what is the right model? You know, should we do a dynamic model, learning by doing, etc. And so the creativity that Jacob brings here, that very, very parsimonious kind of model, you know, without getting into the complications of dynamics and all that stuff, was able to do this. So the very first version we started with Arvind, as Jacob just pointed out, was everybody is served. And then the question became, well, but what if everybody, because monopolists will have a choice about who to serve. And that's when we modified the model, saying if you do endogenize the choice about who you will serve, would you still offer free kind of idea? Because if everybody is served, that's one thing. But if you have a choice to serve, would you still offer free was the question, right? So yeah, thanks, Jacob, for reminding that. There is another question, maybe, Jacob, I'll defer to you about this Bayesian Nash versus dominant strategy.
So we didn't look into that. We didn't look into that too much because the results were so clean under just the standard kind of asymmetric pricing model. And what we wanted to do, since, you know, we're proposing something somewhat radical, right? Give something away for free and you get more money. We didn't want to deviate too far from the norm. So we basically anchored all of our analysis on kind of the most classical economic models. And this was the equilibrium strategy that those papers looked at. Mm-hmm. There's another question.
One last question, yeah.
The presence of competition. Mm-hmm. This is something we looked at a lot, and not only with government competition versus an Arvind kind of company, but whether or not 2 companies in the space could operate under the same strategy. And it gets to be very complicated because you get into sort of cherry picking kind of problems, right? So if, as the question poses, there's a government player whose goal is universal service, okay? What I expect would happen is the for-profit firm would sort of seed the lowest valuation customers to those guys. And it would be kind of like a race to the bottom for the government hospital. And then the for-profit guys would sort of, they'd go down the distribution, but they wouldn't go down the distribution necessarily so much as they otherwise would. And
but,
you know,
they may still offer free service.
They would still offer free service if the volume considerations were strong enough, right? And the other thing is, you know, if you have a government hospital, how is the quality comparing to an Arvind, right? It's a hard problem to look at because even the math in here, closed form solutions in here, and the monopolist problem were difficult due to the non-monotonic path of pricing. So the math ended up getting extremely.
Yeah, math is difficult, but I think one could intuitively think about, so in the model that presented that, you know, because we are comparing with the previous asymmetric information full pay model. We limited to not everybody being served, but lower bound was theta p. So you can imagine that a government service may address the needs of the lowest theta under bar to theta p, and that will still leave the market open to players like Arvind coming in. The question really becomes if, at least in the Indian context, how many of the higher valuation consumers will actually go to a government service? So this is where Jacob was saying that, you could, government could offer that service at the really lowest valuation market, and players like Arvind could be on the higher end of theta, right? But yeah, to show that in a modeling setting, it's just super complex.
Okay,
anyway,
I think
back to you, Debjit.
Yeah, thank you so much, Ravi and Jacob, for coming this evening and presenting to us. I think all of us, most of us belong to operations, and we had many insights. And particularly, we always think that higher the efficiency, the quality suffers, right? But here you give us an example where as the efficiency improves, quality can improve because of variety and other sort of learnings. I think there are many other insights that came out through the presentation. So thank you
just
both.
On that point, Debjit,
Yeah.
Debjit, on that point, what you just said, I want to kind of contest that a little bit, because healthcare is one situation
Right.
where quality should improve with volume. I mean, you have many examples, and especially coming from India. I did a 4-day exec ed in China. And it's strange, in China, people have this exact notion. First of all, in China, the notion is that private sector offers worse quality than public sector, especially when it comes to hospitals. Many top medical graduates in China will not go work for private sector hospitals. They will work for public sector hospitals. And to me, it was doing this exec ed where, 65 business people, and, they couldn't understand the situation in India. And I actually walked them through the Arvind model and Narayan Hridayalaya model, both. And they were completely shocked, right? Why would you offer free service, and what's really going on? And then, how come you have so much volume and quality doesn't, suffer? And I think the Indian models, and we should be proud of that, has actually demonstrated that, and I've got convinced that healthcare is one good or service where you can actually improve quality as you increase volume.
That's phenomenal insight. I think all of us take it from this presentation. And hopefully we can host both of you on campus sometime when your situation comes back to normalcy. And thank you both again. Yeah.
Yeah, I will pitch in for Jacob. He's doing interesting work. You should invite him for a seminar, because this is the beauty of virtual seminars, right? So I'm glad. Thank you, Jacob, for joining in and answering all the hard questions for me. Yeah.
All right.
Thanks, Debjit, for the opportunity. Take care.
Thank you all. Thank you all for joining.
Yeah.
Thank you.
Bye.
Thank you.